So we'll be beginning now. A warm welcome and good evening to all. Rural Service Bootcamp is back with a ninth session this Sunday, and we'll be dealing with a much requested and much needed topic. We'll be having a session on basics in trauma management. The session will cover clinical and radiological assessment of common fractures and how to manage them in a resource limited setting. To guide us through, we have Dr. Kiana Mirza from the batch of 2012. We are so happy to have her with us. She's a familiar face to many, and she's also one of the few young female orthopedicians in the country. She did her UG from St. John's Medical College and PG in orthopedics from Father Muller's Medical College. She's a member of the Royal College of Surgeons of England and is about to move to the UK soon. We are so grateful to have her because she herself volunteered in the academics group to take some sessions and after helping several bonders with ortho doubts. Thank you and welcome, Kiana. A few reminders, please be interactive during the case-based discussions and don't worry about making mistakes. We have all been there. Be more interactive and so the session is easier to remember and retain whatever you have learned. Please keep yourself muted throughout the meeting. If you have any query, please type into the chat box or join it Academics WhatsApp group. A feedback form will be shared on both the above mentioned platforms. Please fill it before you leave the meeting. Over to you, Kiana.
Thanks a lot, Tijo. I'm extremely proud of you and Alex for taking this initiative. I think we can all agree if we all had this as bonders, we would have really benefited a hell of a lot. So kudos and good job. Hi everyone. So I'm just gonna share my screen and so far Judah has volunteered, and if anyone else wants to also kind of get in on the whole thing, please just raise your hand or something, and we'll discuss each case. All right. So because I y'all don't need lectures, so y'all have had enough I think during undergrad. So I hope everyone can see my screen. Yeah. So yeah, like Tito said, I am from the batch of 2012. But my relationship with St. John's started the day I was born. I was born in the St. John's OBG ward, and I am born to Dr. Ophelia. She is batch of 1982. Very proud to be a second generation Johnite. And took part in a lot of sports. Few of you may remember me from that. And earlier this year, as an overkill, I went ahead and married another Johnite as well. So this was my bond experience. I stick by the fact that I think one of the best decisions I ever made was to go far away and do my bond. I'm extremely proud of having done it, and I think it was one of the best years of my life. A few of you may recognize Nikhil Ratitra. He's from 2010 batch. He's over here, and most of you will recognize Rajnikant on the top right. But below is my on the lower two are my Masuri family, and they really made me a much better doctor. So very grateful, and I hope all of you also utilize the opportunities you have during bond to become really good clinicians. So let's cut to the chase, because we've got a lot to cover in a short period of time. We may split this over two classes depending on how much of an overkill it's turning into. So whenever there is an ortho case, you have to do a good thorough clinical assessment first. All right. So that is your history and your examination. And there are a lot of telltale signs, and we'll go over a lot of them during this. And then to do a good radiological assessment so that you reach a very, a good enough tentative, provisional diagnosis, so that you can guide your first aid management and medicating the patient. And your job ends right now at the level that you all are at documentation and referring. So what I want to be able to cover are just these three here: this first, second, and third. All right. So this is what we want to be able to do, because I know you all know how to do paperwork, man. Everyone has done internship in St. John's and knows how to be a clerk. So this part I'm not worried about. And definitive management is just out of the scope of this right now. Okay. So coming to clinical evaluation, there are a lot of factors you have to take into account. So, there are a lot of common fractures that happen in the elderly, a lot of common ones that happen in kids. A lot of delayed presentation. So always find out the real story. A lot of people actually conceal this kind of information. And the mechanism of injury will actually guide you to understanding, what fractures you should look for. So for example, if someone has fallen from a height, you definitely have to think about, especially these construction guys who will come to a lot of your bond centers. You have to think of spine fractures, fractures in the pelvis, the calcaneum, fractures around the hip. So be aware of the mechanism. Pain, you guys already know how to take a good enough pain history, I'm sure. What was the pre-injury status? So, a lot of people will come saying that, there's this elderly lady and she's got hip pain and she's been in bed, but before that she used to walk. So please have a high clinical suspicion for a hip fracture. And this is something a lot of people forget. Past history and comorbidities. Please, please, please be aware of comorbidities when you give medication, especially to patients. Okay, and we'll be going over different painkillers, when to give what and when not to give it also, which is, I think, all the more important. And examination, the very important bits that pertain mainly to ortho are here. Okay, so you'll have to look for these, and the most important one has to be if they've got neurovascular deficits. Okay, so because that will give you an idea of how severe the injury actually is. So attitude and deformity is something that we'll be going over now for you to be able to understand how to identify what a telltale sign of any particular fracture is. Okay, so can we have Jura, can you unmute yourself?
Hello. Yes.
Yeah, hi.
Hello. Hello.
Hi, buddy. So, here what do you see over here? Just tell me off the top.
There appears to be discoloration over the midfoot, over the base of the first metatarsal, and there's discoloration of the all the other toes.
Okay. That I think those look like tan lines to me, but is there anything else you're seeing?
Uh,
What's this?
Swelling.
Yeah, exactly. So there's a swelling there. So I've not given you history, so that's also my fault. But when you, okay, so let's assume that this person's had some amount of trauma. I'm going to say that this person was lifting something heavy at home, dropped it on her foot, and has now come to you with swelling. What X-ray do you think you'd be able to order for this patient? Because now what we're trying to do is just you guys know when a person presents. It's what you do next that really matters. So say you're able to elicit tenderness here. What X-ray will you order for this particular patient?
Left foot AP oblique.
Yeah, very good. Okay, it's not a lateral. A lot of people still write lateral. You can get a lateral if you're suspecting a calcaneum issue as well. All right, so that's when lateral comes in handy. If you're suspecting a calcaneum fracture, it's an axial and a lateral view of the calcaneum. But for a foot, like you said, it's an AP and oblique. Good job. Can you tell me what you see over here? Okay,
I
so it's a
see.
child with a fallen outstretched hand. Okay, just for the sake of figuring it out. Yeah.
Okay. So I mean, apart from the obvious turmeric application,
Yeah.
there appears to be um, a swelling over the proximal radius.
Okay, so let's
Uh,
not say a bone because it's a general region, right? So you can even say the proximal
forearm,
forearm,
forearm.
or you can even say the elbow. Okay. Yeah.
Although I would also like to see like near the wrist. Uh,
Very.
but here I can definitely see a swelling over the proximal forearm.
Yeah.
The
Okay.
the
So what
lateral.
would you like to order for this patient?
So I would like to order a right elbow AP lateral.
Yeah. And depending on where you're getting a lot of the swelling and tenderness, you can always ask the technician to include a little more of the forearm as well. Okay.
Yes.
So good job. Okay. And we've got another one now. Okay. So tell me what you see.
Any history?
Yeah, okay, fine. Let's give you a history. This child was playing on a tree and then fell from a height and landed on the left upper limb.
Okay. I'd like a elbow,
No, tell me
AP
what you
lateral.
see. Tell me what you see. So let's talk about
Okay, so
what problems you can see. Yeah.
okay. So I'm seeing two wounds. One is over the left elbow,
Yeah.
anterior aspect, and one is near the wrist.
Yeah, very good. Okay. Yeah, so what would you like to do for?
Discoloration in between.
Yeah.
So I'd like to ask for this thing. I'd like to ask for a left elbow, AP lateral,
Uh-huh.
and left wrist AP lateral, and I'll ask the X-ray technician to cover good portions of the forearm in both.
Okay, so good job. You've identified that there are two wounds. There's also deformity here at the wrist. Can you see this angulation here that's happening? Okay, so don't miss that. So that means that there's mostly a dorsal angulation right here. Can you see that?
Yes, yes.
Yeah, so that could be a fracture, right? So
Got it.
well done. Only thing is for a wrist, it's PA lateral. Okay. So this is something I think a lot of people miss is that it's not AP for wrist, it's PA. All right. So can let's see if we can hand over to somebody else on the group. Um, how about Mitchell? Do you mind joining us for a bit if you're all right with it? We're just discussing. If you could unmute your mic, is that all right? Okay. Anybody else? Sandra. Sandra, do you mind unmuting just for another couple of cases? Um, Leander?
Yeah.
Hi.
Okay, we'll take turns then. So, okay, Leander, you mind staying on? Yeah. Tell me what you see here. So this is not the greatest angle for a photo, but I'm just going to tell you that this is the arm of a person. That's the sleeve over here. All right. And here's the elbow, and this is the forearm. Again, fall from a height. Okay. So tell me what you see.
Hello. Sorry, I have to go. I just got call from OPD.
Okay, no problem.
My boss.
Sandra, could you come back on? Is that okay?
Yeah.
Yeah. Okay. So Sandra, come talk to me. Tell me what you see.
There's a swelling in the mid portion of the forearm
Okay. Here's
and a
it.
deviation. Yeah.
Okay. Here, this is what you're talking about. There's angulation.
Yeah.
Yeah, good job. And this is well, right? So there's a
There's a
wound.
open. Yeah.
Yes, excellent. Okay, so what X-ray would you like to get for this patient?
Uh, uh, right. I can't make out if it's the
Okay,
right
that's all
hand or
right. We'll
the.
say it's the right. We'll say it's the right for now. Just you can tell me what views you'd like to get. It's not your fault that the image is such. Tell me, what views would you like to get?
AP lateral.
Yeah, okay, of the forearm. So, and that will include the wrist and the elbow, all right?
Yeah.
Okay, so what do you see here?
There's a wound on the dorsum of the right foot,
Yeah,
open wound, and there's swelling around it, and the tendons are visible.
very good. Okay, so even if you don't have a fracture, doesn't mean that there's no problem. This person will need a tendon repair because you can see a cut end over there. Okay, so what X-ray will you get for this patient?
The right foot, oblique.
Okay, anything else you would like to get? Because can you see it's extending proximally as well?
Yeah, the ankle.
Yeah, so what views would you get for the ankle?
Not sure. Epilateral.
Yeah, don't worry about it. See, like you know, confidently answer, even if you're wrong. That's why you're here, and we'll figure it out together. Okay. So, Sandra, I'm going to hold on to you for two more cases, if that's okay. So, this is a 70-year-old male, all right, with a slip and fall at home and was carried to hospital, but he's unable to bear weight on the right lower limb. And now you are examining this patient. In this image, can you tell me what you see? What is different between both the limbs?
The right foot is externally rotated.
Very good. Anything
Um,
else?
and the shortening
Very
of the limb.
excellent. So you can see over here that the lateral border of the foot is lying against the bed. All right. The heels are at different heights. Okay. And here you can see the patella is facing the ceiling, whereas here it's facing outwards. So this is a telltale sign that this person probably has a fracture around where?
Um,
Sorry,
uh,
sir.
the hip bone,
Very good. So what X-ray do you want to get for this person now?
um, hip epilateral, pelvis
So
epilateral.
what would probably, yeah, no, you don't need to get a lateral for pelvis, but getting an AP of the pelvis would give you a good idea. You can also, when you have an AP of the pelvis with both the hip joints, you can actually compare the right to the left as well. Okay, so good job by getting a pelvis AP. So this is the X-ray that you have. Okay,
Okay.
okay. Now tell me what you can see.
Um, and there's a fracture of the neck of femur.
Okay, very good. So you can see that over here, right? Yeah.
Yeah. Yeah.
Okay. So it's nice to be able to compare as well, but there are now, so I think a lot of people wanted to know how to read a lot of these x-rays and what to look for. So I'm just going to tell you very briefly. You should basically be able to look for the like very specific lines in a pelvis x-ray that will tell you if there's a fracture or not. Okay, so do you know a name of any of the lines by any chance? If you don't, it's all
The
right.
Sheldon,
So tell me. Good job. Come on, tell me.
Sheldon's line.
So close, Shenton's line. Okay. So that
Sheldon.
is, yeah, the medial border over here of the neck comes here to the obturator foramen. Okay. So that's Shenton's line. Here you've got a break in Shenton's line, so you were able to make that diagnosis. All right. Another two to remember, okay, is here you've got an iliopectineal line, okay, and an ilioischial line. All right. So when you've got rami fractures and stuff, and even when you have acetabulum fractures, just always watch out for these lines. Okay. You also have a teardrop, which I don't think you'll be able to see very clearly in this particular X-ray, but for the next one, maybe we can. There are a few more X-rays, so maybe further down I can show you where the teardrop is clearly. All right. Okay. So we'll go to the next one. Come, Sandra, tell me. So we've got a 65-year-old gentleman. He's had a fall on an outstretched left hand, and there's swelling and deformity of the wrist. So this patient had come when I was in Bond. Okay. So he's supporting the left hand with the right, isn't it?
Yeah.
Yeah. Okay.
There's
So I'm gonna zoom in a bit for you. Come, tell me.
there's swelling around the wrist,
Yes, there
and
is.
there's a inner fork deformity.
Yeah, it's extremely slight, so I don't blame you for being uncertain about it. It's extremely slight, but yes, you're absolutely right. There is a dinner fork deformity. Okay. So this is your X-ray. So can you now tell me what all you see here?
There's a fracture at the head of the ulna, distal part of the ulna.
Okay.
Mm,
What about
displacement.
the most obvious one?
The radius and the ulna.
Yeah, so this is, so again, like we mentioned earlier, the X-ray that you will say is that you want a PA and a lateral, not an AP lateral. Okay, so this is what you're looking at over here is a PA view. This is the lateral view. Okay, so here you can see that the ulna styloid is fractured. Okay, so because distal ulna unfortunately encompasses quite a large chunk over here. And this would still be, if you had to say that there was a head, it would be this entire chunk. So this is known as the ulna styloid. All right. Similarly, this is known as the radial styloid. Okay. So very good. You've identified that there are two fractures. All right. So, and very good. You were about to tell me where the displacements are. So you can go ahead. You can tell me what displacements you can see right now.
I'm not very sure about that.
Okay, no worries. We're going to anyway discuss this one in a little more detail further on. So we'll come back to it. Okay. But good you've identified it. Okay. So now, Judah, do you mind coming back on?
Hello, ma'am. Yes.
Yeah. Hi. So you've got a
So,
14-year-old girl, all right? She's not had any trauma, but she's got a bilateral deformity and pain on the ulnar side of the wrist on and off. So tell me what you see.
ma'am, I see some swelling over the left wrist.
Okay.
Two looks like almost like two swellings.
Hmm. Okay.
Uh,
What any deformity that you can see?
deformity.
You can look at your own wrist and then look at her wrist and tell me as well. Okay, no worries. So can you see that the entire wrist is kind of volarly displaced a little bit? It's not
Yes.
it's not similar to your own wrist. And very good you saw this area as a swelling. Actually, it's the radius, all right? What you're seeing over there at the back. And this, sorry, what you're seeing over here is the radius. What you're seeing here, this one, that's the ulna. So which X-ray are we getting?
Ma'am, you take a left wrist PA and lateral.
Okay, very good. So she's got bilateral deformity. You can get both, but we'll just
So,
talk about her left wrist for now. Okay.
so,
So
ma'am,
tell me. Yeah.
ma'am, it looks like there's a lateral and a posterior displacement of the ulna. Um, no, here, and a posterior displacement of the radius.
So
Uh,
actually, what it is that there's a your I want to show you over here. Do you what is this, Judah? This area, this line that you can see in the ulna. Is it a fracture or what is it? And the clue is that this person is 14 years old. All right.
Artificial plate.
It's the physis. Okay, so that's the growth plate, right? So in a growing child, you will have a growth plate. All right. So is something missing on the radius then?
The the growth plate is missing, and it looks like it's hollowed.
Yeah. So what's happened is the growth plate has prematurely fused on the radius. So the ulna is growing. That's why the height of the ulna is higher up. Okay, so the reason I've put this is because now she's got a deformity because the distal radio ulnar joint has also gone for a 6. The ulna is growing at a much faster rate. The radius is not growing. So the carpus, that's the carpal bones here, they've all moved volarly and the ulna has moved dorsally. That's why you are seeing that swelling. So the reason I'm sharing this is that not everything you see, even though it has a deformity, not everything has to undergo splinting because it's trauma. This is a cold case. It's what we call a cold case in ortho, where it's not a trauma case. All right. So don't try splinting these kind of people. Refer for further management. Okay.
Okay.
Right. So this is extremely important. Up until around 2 months ago, I was working at a Taluk hospital where the technician was very, very adamant on only taking one X-ray, and that got me into a lot of trouble with a lot of patients because a lot of things ended up being misdiagnosed. So please always get two views because your objective when it comes to getting an X-ray is you want to be able to take a two-dimensional image and get a three-dimensional idea. And for that, you have to take the X-ray in two different planes at least. Okay. Um, Always when you get an X-ray of any bone, try to get the joint above and the joint below because you never know if that bone is fractured at multiple places or if the joint has dislocated. Much like in a Galeazzi and or a Montegia variant, you can actually have a fracture with an accompanying dislocation that you could very well miss because you didn't get good X-rays. So getting two sides. So why would anyone want to get two sides, right? So when you get two sides, it's usually when you're trying to look at like a pediatric X-ray. So a lot of these ossification centers and they turn up very late. Many a times the physis also it looks very jagged. It could look like a fracture. You could be a little unsure. So when you X-ray the opposite side, you have a comparator at least, and that is obviously provided that your comparator is normal. Two occasions. Judah, do you know any time that you would have to take an X-ray on two separate occasions?
Uh, One is the immediately when the trauma has happened, and one after splinting, after management, to see how much it has healed.
Okay, I agree with you completely. That is when you're doing follow-up X-rays. Also, many times when, especially like around the carpal bones and stuff, sometimes the first X-ray doesn't show the fracture because it could be a very fine line, and you may not be too sure. So you can always call the patient back after 5 to 7 days, and many times those fractures finally reveal themselves in a repeat X-ray. So this is a very important thing to keep in mind as a bonder, I feel. When you counsel a patient, just because the X-ray may look normal, when a patient has come to you in a lot of pain and a lot of distress, don't try to convince them that they don't have a problem. Always say, look, right now, it seems fine. Please come back. So then it shows that you're not trying to discard the patient. All right, so just be very wary of that. Okay, so again, two visits is because of regular follow up and stuff. Two opinions, never be afraid to ask. Okay, even now, frankly, like even though I'm done with my MS and all of that, often I like discussing cases with my seniors. I know professors who still love to discuss cases because there's a lot they can actually gain from another person's insight. So never feel ashamed to ask for help. Okay. Okay, Judah, tell me, do you like this X-ray?
I do, ma'am.
Yeah.
Um,
Okay.
so, I
And
mean, first off, if the growth plates appear fused,
yeah.
it's an exit the ankle joint. That
Yes,
is
very good.
I think it's AP. So, um, I can see like a hollowed out aspect of the distal tibia, right?
You're talking about this, right?
Yeah,
Okay, and you're talking about
and
this.
that one. And
Yeah.
moreover, I'm not entirely sure if the lateral malleolus is completely is completely formed. Is
Okay, so I'll
and
tell
also
you, there's an open wound. Okay, like that is why this is gas. This is gas from a wound. So gas has entered, and that's why you're seeing that pocket. Okay, so is there anything else wrong with this X-ray? That I mean, something where like, can you see a fracture, or do you want any more information? What would you like to do if I give you this X-ray for a patient with an ankle injury?
I'd like to see what it looks like on the grass
On
and
what? Sorry.
on grass, the grass picture.
Okay. Yeah. Anything else?
And whether the
Radiologically?
okay, the ends of the
So are you happy with one view?
no, I need a lateral view.
Okay, that's what I was hoping for. This is
Yes.
the same patient. Okay, so
So
here you can see there's this gas shadow over here because of an open wound. There's a little bit of debris over here. All right. You can see this abundant soft tissue swelling. Can you see that? That's pretty large. Like when you compare it to this side, right? So I mean, obviously, this person's come in a lot of pain with some swelling and a wound, but without the lateral, you'll miss this. And this fracture actually needs to be plated. There needs to be a plate put at the back over here, so this person cannot be sent home or managed conservatively. Okay, so I'm trying to just highlight the importance of having two views because this gave you no information whatsoever. Can we agree on that?
yes,
Okay. Yeah. So tell me, looks quite bad. Tell me what you see.
um, so I see multiple fractures over the tibia
Mm-hmm.
at two places, and it looks like is the first view a lateral view and the second view a AP view?
Yeah. Yeah, absolutely. Yeah, you've got both views.
Okay. Uh, and it looks like the fibula and the tibia have like the tibia is dislocated anteriorly and the fibula is dislocated. I mean, fibula is around the same place, but the tibia is dislocated anteriorly.
Okay, so you're talking about displacement. So dislocation,
Displacement.
just for your for your future reference and stuff. Dislocation is a term we use mainly for the joint. Yeah, we don't use it for the bone. So you can see, yeah, I agree. There is some amount of displacement. You've got a nice spike over here also, and so the distal portion has come anteriorly. So this is what we would call a spiral fracture because it's gone around like this. Okay, and then it's resulted in a segment over here. Okay, so are you happy? Is this enough information for you?
We can get a 3D reconstruction.
No, that I don't need that. I'm saying when you look at this X-ray, is this X-ray enough? Are you happy with the way this X-ray has been taken? Because we just went
No,
over a couple
there's.
of rules, right?
It looks like somebody has like there's some sort of imprint on the film.
Okay, so actually that is because there's a slab. So can you see there's a slab that's put here? And the slab is extending till up here, and this has been photographed on a system. It's not been taken on a film. So that's probably why you feel that way. But is there something from the rules? So I'm going back to the rules that we were discussing, okay? Yeah. Is there anything missing?
There are no pictures of the joints. We need the joints.
Very good. So you've got the ankle joint, all right. I agree it's not the most clear, all right. But do you have any idea of the knee joint here? No,
No,
right?
no, no. We need the knee joint.
Shall we repeat X-rays?
We can do yes. I think we definitely need to repeat X-ray of the ankle and we need a knee.
No, you have to repeat the leg, and that is when you get the knee and the ankle. You just have to have a good technician. This is what I meant. My technician gave me hell. Now what do you see?
So now I see like a very clear, a clear picture of the spiral fracture of the tibia with more information even, uh, and with the proximal fibula fracture.
Very good. And this is something people end up missing. So this is so this might help you all for MCQs as well. Sorry. Okay. This is known as a Mason's fracture. Okay. That's how it's spelled. Forgive my handwriting, I'm not great with a stylus. But what happens is this spiral fracture, right? It has gone up like this, come around like this, and then gone through the intraosseous membrane and gone up here. So there's disruption of the intraosseous membrane.
So it's a
Um,
twist injury.
so it would have been a twisting injury. Yeah, absolutely. So now, is there any structure here that you would be worried about?
The
The clue is it's a nerve.
the peroneal nerve.
Yes, it's the common peroneal nerve. So you will
Okay.
realize then that when you have a person in a slab, you've not been able to check for foot drop properly. Okay. And you've missed this entirely because that person wanted to take shortcuts, saying that I think there's only a tibia fracture. So remember the importance of always showing that there's a joint above and a joint below. All right. Okay, so we'll give you a break. I don't want you to burn out. Who can we have now? Um, Alicia, do you mind joining us?
Yeah.
Yeah? Okay. Come, tell me, what do you see?
Um, this is the X-ray of a shoulder joint.
Yeah, very
Here,
good.
with one view, PA view,
This
AP
is
view,
an
sorry,
A.
AP view.
Yeah, good job.
And I can see that the shoulder joint is dislocated. Like,
Okay, it's
hmm,
not dislocated. Here you can see the glenoid over here. Okay,
huh.
and it's articulating with the head. So it's not dislocated. But is this a skeletally mature or immature person? Can you see any growth plates?
No. Ye,
Okay, so I'm just clarifying for you. This
I'm
is a
not.
physis. Okay, no problem. This is how you learn. It's all right. The only thing is when you all see, you will kind of get a better idea. So don't be afraid to make mistakes today. Okay. So this area that you can see here, okay, these are growth plates. All right, those are not fractures. That's what I wanted to show you. And I can understand in your current setting, any of you having this doubt, all right, about where the fracture may be. And this is where the two sides can come into play, okay, where you can take, now this is the left shoulder, right? So you can always also ask, look, I need the right shoulder, which is the well side, obviously if there's no trauma to it, to be able to compare it to this side and really know what's wrong. Can you see a fracture anywhere here, Baba? Just let me know if you can see anything.
In the shaft of humerus, the proximal side.
This one?
Yeah, towards the laterals. Yeah.
So this is actually the fracture. It's going like this. It's coming out here. Okay, it takes time to figure it out. It's all right. But here this is the telltale sign because here you can see the cortex is disrupted here. So you've got loss of cortical continuity. This lovely white line here that you can see, that's the cortex, all right, of the bone. So here you can see that it's lost continuity. So there's an undisplaced fracture of the proximal humerus, which is not got anything to do with the physis. So the physis is a growth plate. Okay, this is in all growing kids. You will see this. I don't want you to get confused and suddenly think that that may be the fracture when the fracture is actually down here. Okay. Any doubts?
Yeah, I have a doubt. Is there a
Yes.
fracture on the lateral side as well?
You're saying on the lateral cortex?
Yeah.
This could be an extension of the same fracture.
Okay.
It could be. But the more obvious one is this.
Okay.
Okay? Right. So now I'm keeping you with me for this one, okay, Alicia? Just this. So unfortunately, I didn't have my own patient's x-rays for this. Forgive me. This is a patient where they were having scaphoid side pain. And you know what? One thing is this x-ray looks quite shitty. Uh, but you can't really see the line clearly, can you? Like of the fracture?
Uh, Very no.
I mean, I can't see it. If you can see it, I think you should probably take up ortho. But if you
No,
can't
I
see it,
can't.
this is why you wait for 5 to 7 days, okay, for the patient to come back. And then you repeat, and then the fracture just reveals itself. Okay, and accordingly, then you can plan management. So this is the idea of doing this on 2 separate occasions. Okay. Okay, come, let's go into splinting. Why do we splint, Alicia? Like why do we do it? Say anything, it's okay. Hello? Are you there?
Yes, yes, I'm there.
Yeah,
Hello.
okay. Tell me, okay, I'm telling you, Alicia, right now, I'm told you you've got a fracture. You've got a fracture in your forearm, all right? Okay, so I'm now telling you that you've got this fracture and you have a hell of a lot of pain. Okay, so if I splint it, will your pain reduce?
Yes, because of
Yeah.
immobilization.
Very good. So it will give you a lot of pain relief. If I don't splint, do you think the swelling can come down? Because you will have some hematoma, some edema, this and that. So can your swelling come down if I don't
Uh,
splint it?
no, I think there will be mobility which will not let the swelling come down and fracture will
Absolutely.
be formed.
Exactly. Okay. So that's the main thing. You want to give the person relief. All right. So that's why we splint. So now we're going to just briefly talk about the rules of splinting, the materials, and always remember when you have a person who has got a fracture, any limb edema, please elevate the limb. Okay, ideally above the level of the heart. So if you've got a distal radius fracture, please put a sling for that person so that they've practically got their hand near their heart. All right. And give adequate pain management and anti-edema measures like that. And we'll talk about antibiotics as we go on. Okay. So Alicia, can you read the rules?
Yeah, rules of splinting: correct length of the splint, immobilize the joint above and the joint below, all fingers and toes should be visible, adequate padding, and check distal neurovascular status.
Okay, very good. So always make sure you get the right length. When do you like you should know when to go for a below knee slab versus an above knee slab. Same thing with going below elbow or above elbow. All right. Immobilize when you've got a fracture. Say, for example, you've got a fracture somewhere in the forearm. I'm going to say you've got a radius fracture. All right, proximal radius. A lot of the muscles that insert onto the proximal radius and ulna, they cross the elbow joint, right? So the problem is if you put a below elbow slab, thinking like, you've gone proximal to the fracture, the muscles that create a lot of movement at that area are not inhibited at that point. So you end up actually defying the purpose of what you're doing. Okay, fingers and toes should be visible. Why do you think it should be visible, Alicia?
To check for cyanosis,
Okay,
and like if the plaster
cyanosis.
is not too, the cast is or the slab is not too tight or too loose.
Very good. So you want to be able to check if any of the toes are becoming gangrenous. So there have been times where if you don't keep it exposed, a lot of times if it's too tight, you can actually lose a toe. So it's not something anyone should have to go through. So you should have adequate padding and always check your neurovascular status before and after applying any form of splinting. Because if you end up manipulating the fracture, trying to do a reduction, you must check if you have got any neurovascular entrapment. Okay. So, Alicia, what materials for splinting do you have among all of the ones that you can read on the right?
POP.
Okay, very good. You have POP.
Yeah.
Anything else here that you have?
The cardboard which they use sometimes,
Very good.
like
So
to.
I've decided, I think the most universal one for all of you all will probably end up being cardboard for the very simple reason that all of your bond centers are running some sort of pharmacy. And no matter what happens, those materials and drugs have to be brought in cardboard boxes. So I think we'll have to make we'll have so the way I see it, clay is a bit of an overkill in my opinion. I think I mean I really wouldn't know how to do it with, like, trying to make clay set fast. It will take too long. Malleable splints also, they're a little expensive, and a lot of patients will not bring them back. Wooden planks are an option. Only thing is, you if you want to go above elbow and stuff, it's a little difficult because you won't be able to create a fold like this for a 90-degree flexion. Cardboard and POP, we can do that. All right, so we're going to talk about it. Um, yeah, Alicia, I'm going to just let you know, I have put both of these. Okay, I did this in 2018 when I was doing my bond in Missouri. I did this in 2019 when I was a PG. What's the one problem you can see in one and not the other?
Um, the one in 2018 is
Hmm?
it. Um, I think I'm not sure
It's
actually.
okay. Take your time. Don't panic. Just look at it calmly. Is there any mistake I have made in the right one instead, which is not there in the left?
And not all the toes are visible in the.
Exactly. Very good. Take your time and answer. Look, it's all right. Okay. Very good. This was pointed out to me by my senior from 2007 batch. His name was Matthew. I don't know if any of you all would have met him, Matthew Sebastian. I remember showing this to him and I was extremely proud. And then he brought me down to earth because I made this very valid mistake. And I remember having to cut the cast over here to expose that last toe. Okay, so good job, Alicia. That's the mistake I had made. Okay. So let's look at how we can use cardboard. Nice thing is all of y'all will have some access to cardboard. I agree it may not be as thick as the card you're able to see here because that's quite a thick piece of card. But you can even layer it one on top of the other and prepare some of these in advance. So what you need to do is this cut can only be made once you finish measuring the patient. Okay, so what you'll have to do is make sure that you first you take the cardboard before you apply it onto before you cut it, apply it onto the forearm. Okay, to be able to make sure that the wrist is not dangling off. See, if the wrist is dangling off, you have not immobilized the joint, you've only then immobilized the proximal joint. So the movement at the distal joint is going to cause a lot of distress. So please first measure, then make a cut, create this fold, put a good amount of padding. You don't have to use like these fancy Gamgee pads and stuff. You can just use your normal medical cotton, layer it, okay, and secure it. But please, for God's sake, don't create compartment syndrome in these patients. I've seen a lot of people tie very tight bandages. Okay, I would rather you leave the fracture as is than create compartment syndrome. So just make sure it's secure. Don't make it tight. Okay. If anyone wants to give this a try, and if you need guidance with your patient at that particular point in time, please give me a call and we can figure it out together. Okay. And please, after that, if you are doing ice pack application on top of the area with edema, please make sure that you cover the ice pack, or if you're using actual ice, make sure it is covered in a cloth so that you don't cause frostbite. And Alicia, what are they doing over here?
Uh, like traction, little bit traction.
No, so what they're doing here is they're checking neurovascular
Okay.
status. Okay, so please always just check. Tell them to lift all the fingers. So it's very easy to just remember one test for each nerve. Okay, for the radial nerve, for ulnar nerve, for median nerve. Okay, just try to make it a habit to always check. So now we'll switch. Is Sandra still there?
Yes.
Yeah, hi Sandra. Okay, so Sandra, this is not a patient I saw during my PG, not a patient I saw during bond. This is a patient I saw in Muglur when I was in my Comet posting. My batchmate Stalin, he's from radio. I don't know if many of you all will remember him, but he's a staff there now, so I'm guessing you all probably remember him better than you remember me. Stalin and I were posted, and this guy came with a humerus shaft fracture. We didn't have anything to, I don't know if Muglur has resources now, but at that particular point, we had absolutely nothing. This is a very easy thing to do, and everybody will have access to at least a bed sheet in their hospitals, and also have access to, like, or you can even ask the patient party, please bring a dupatta from home, and they'll gladly do it. Because, and you have no idea the amount of relief this man had. If you're ever doing this for a humerus shaft, remember the radial nerve also is there. Please always check for any wrist drop, finger drop, or any sensation, loss of sensation in the first web space that's over here. All right. Right. And I will share this, just remind me later, and I will share this image on the group so that you guys can try this out. Okay. Whenever you have a case. Okay. So come, tell me, we've got different analgesics that are there. When do you not give NSAIDs?
When there's a renal
Very,
involved, any renal disease,
yeah. Anything else?
gastritis,
Okay.
um,
Would you give it in a patient with ischemic heart disease?
mm,
Sandra?
uh, yeah, I'm not sure.
Okay, so this is actually a very large, like a very major concern, and I feel like all of the physicians have a problem with ortho because of this. Because NSAIDs are the most commonly prescribed drugs, especially in rural areas. They're very easy to procure. They're always available, whether you need them or not. Um, I for sure very good, because yes, it is a lot of metabolism happens. A lot of metabolism and excretion pathways have to really dictate what drug you use. These cause some amount of vasospasm. Okay, which is not something we're taught, unfortunately. I learned it, I think, when I was only a PG, which is such a shame. So I'm glad I get to tell you all about it now. Please avoid diclofenac in patients with any form of ischemic heart disease, and NSAIDs generally in patients with uncontrolled comorbidities like diabetes and hypertension. If you have access to better drugs like etodolac, so that's your etova, ER, and those kind of drugs, you can give them in patients with diabetes and hypertension, but please don't give them in heart disease. Okay, right. Now, what about opioids? When will you not give opioids?
In children,
Okay, then.
um,
Okay,
not
so Sandra, tell me, do you remember the mechanism of action of opioids, like what receptor they act on?
Hmm.
from
I don't
pharma?
know.
So do you remember the mu receptor?
Yeah.
Very vaguely, yeah.
Yeah.
Do you know where that mu receptor is mainly located?
The neurovascular junction.
No, it is okay. So, is tramadol or morphine, okay, are they centrally acting opioids, or how do they act?
Centrally acting.
Very good. So, if you have to act on the central nervous system, where will you act? I'm drawing the brain for you, Baba.
The brain.
Okay, that's the brain. I'm sorry, I'm not an artist. I was only good at sports. Yeah, so it's centrally acting. So be very careful in patients who have polytrauma if you have signs of head injury. Okay, in these particular patients, especially if you've got any signs of head injury, avoid it. Opioids will lower the seizure threshold in these patients. Okay, and if a person has a seizure, you will have to deal with concomitant cerebral edema, and you've given them one more problem instead of one less problem. Okay, so not given in patients with head injury, any form of dementia or altered sensorium. Okay.
Okay.
And oral opioids, please also avoid in patients with constipation. They get very upset. I've realized most of the Indian population, their sentiments lie within their bowels. If they haven't taken a shit, they are the most upset group of people you will ever come across. Please avoid in patients with chronic constipation. Okay. Paracetamol, paracetamol. Come, tell me. When will you not give it? It's very, very
Tablets
safe to give
in
normally. So
CLD or
very good in any form of liver disease, because you will then precipitate hepatic encephalopathy, and then medicine will have to get a reference, and they'll be really, really pissed off with you. Okay, so this is when you should not give the drugs, and I feel like knowing when to not give something is much better than knowing when to give it nowadays. All right. Okay, come, can you read the right side of the slide?
antibiotics in open fractures.
Okay.
Thorough wound wash with saline plus dressing plus splint.
Mm-hmm.
Third generation cephalosporin plus amikacin or gentamicin plus metronidazole.
Okay. So what I wanted to communicate is you should definitely, whenever you get an open fracture, even if you have nothing in your center, you will have some amount of, you will have enough saline, because all of your patients will be coming running in asking for glucose. So I know all of you all have this. Please empty at least, like, minimum, I would say, like 2 to 3 bottles of saline minimum should be emptied into that wound. Give a wound wash. A lot of contaminants will come out. All right. We do a loose dressing, okay, and splint the limb. You've got various types of fractures, so I don't know if you all would have remembered your open fracture classification. I do think you all should read the theory behind it. You will get MCQs based on these things. So what I would say is you have to start cephalosporins in all of them. All right. Depending on the level of contamination, you can add these. Be wary again of comorbidities. So Sandra, tell me, when will you not give amikacin and gentamicin?
Renal
Very good.
impairment.
Very good. So you will please avoid it at that point. Even if don't go and say no, I gave it because Kiana told me if it's looking contaminated to give it. Please don't do that. Be wary of what you're doing. Always give a test dose. If you're going to just refer, just at least give the test dose and then refer out. Okay. Um, the more contaminated, so I would say over here, this can just have cephalosporins. I would say a wound like this, you can have the cephalosporins plus a amikacin or gentamicin. And when you reach 3, better to have all 3 antibiotics. Okay, please guys read Gustello-Anderson classification. I don't want to teach you all theory. I feel like you all are all smart enough to read theory on your own because you've made it through MBBS anyway. Okay, so let's switch again. Judah, buddy, you ready to come back?
Yes, ma'am.
Okay. Also, guys, if anyone else wants to join in, just raise your hand. Okay. I didn't want to. I feel really weird forcing people to participate, so I'm just kind of circulating among the few people who are participating. Yeah. So, come, tell me, Judah. Fall on outstretched hand. Talk to me about this patient and what are the deformities you can see here.
So on the essentially there's a distal radius fracture of the right hand, and it's not
Right?
very clear. I mean, right distal radius fracture.
Yeah.
So on AP, it's not very clear, but I think I can see two fracture lines on AP. I'm not very sure. One appears one appears horizontal, and one appears almost like a semicircle.
So actually, this is the one here that you can see. That's the fracture line. This what you're seeing over here, okay, this area, that is the
Not
articular
that one.
surface. Can you tell me where exactly? Here?
Uh, yeah, yes. It's like the
Okay,
like
so
near the interosseous area.
okay, here you're saying.
No. I wish I could. Can you see like some dotted lines, right, going
Here
right
is
into
it?
the half of the what? Yes,
Okay, so that's so basically what I would tell you is over here, this chunk, okay, can you see over here that this area looks a little different to the rest of it?
yes.
Yeah, that's because here you've got cortical overlap. So you can see all of this overlapping with each other. Okay, so that's what you're seeing. It's very difficult to go from a 2D to a 3D picture, but what you're seeing over here is basically the fact that this has lost alignment. You've got what would normally be here, like, in this, when you shoot an X-ray, you are now shooting it like this. Right. So because of the tilt that you're getting, you've got a dorsal tilt here, right? So because of that, the things that are overlapping are different to what they normally would have been. So you're seeing some weird stuff here, basically, if that makes sense.
Yes, ma'am.
No, if you have a doubt, stop me and we can clarify it now itself. No worries.
Got it.
Okay. So when you see this, can you tell me the deformities you can see?
Okay. So is the anterior side facing to the left and the like
So this
the
is this is volar, this is dorsal.
dorsal? So the looks like there's a dorsal displacement.
Very good. Anything else?
On the
So do you remember? I mean, I remember. I feel like no matter what book I've read, the only book that ever taught me all of the deformities of a distal radius fracture in a way I could remember it was Maheshwari. I'm assuming all of you all read Maheshwari itself, since the one of the authors of it happens to be a Johnite. But there are one, two, three, four, five, six. There are six deformities in a Coley's, right? Do you remember?
mm,
Okay, no worries.
dorsal.
So this is what I used to do. I used to remember it this way. So you've got two L's, you've got a lateral shift, you've got lateral tilt, you've got two D's, it's dorsal tilt, dorsal shift. And these are the ones that most people forget. Okay. So that's impaction of fragments and supination. So here you can't see the loss of radial height and stuff very clearly, but if I show you that other radius fracture that we had prior. So you can see it a lot clearer. 1 second. Are you able to see the screen?
Yes.
Okay. So here you've got a radial shift. The styloid has moved this way. All right. Okay. And the entire wrist has gone to the radial side and it's also tilted radially. So that's your lateral shift and tilt. Okay.
Yes,
Here
ma'am.
you've got a dorsal shift as well as a dorsal tilt because of that angulation. So what is this impaction of fragments? Can
Like
you?
that
Yeah,
overlap, that is it, that overlap?
very good, excellent. So you can see over here, I'm outlining the distal radius here and here. Can you see this is overlapped,
Mm.
right? So coming back to our other patient that we had seen earlier, I mean seen just now. Yeah, right. Okay, so you've got a bit of overlap here, okay, here and here. And you've got a lot of overlap dorsally, right?
Yes, ma'am.
Okay, so you want to be able to give traction over here and be able to disimpact it. But the way you do it also matters, okay? So the beauty of a fracture like a Colles fracture is whatever the deformity is, you just have to do the opposite. It's just like whatever it is, I'm going to do ulta and it's going to work out. So you need to basically undo what has been done. So when you disimpact, can you see over here, there's some cortical overlap in this image?
Yes, ma'am.
Okay. When you exaggerate the deformity, that means when you make this go a little more dorsal and then give traction, you can actually create cortical alignment. If you just try to give traction, it will usually slip back, or you might actually cause some some amount of fracture of the dorsal cortex. So you have to, when you are doing this, you have to basically exaggerate the deformity and pull. Guys, if you are ever trying to do this reduction, remember, always it's a three-person job. If you are alone, forget about it. Splint, refer. Okay? There's no shame in not being able to do something, just do no harm. All right. And if anything you're going to do is not going to benefit the patient, it's okay to not do anything as long as you are not causing any form of harm. Can you see over here? They're giving traction, right? So when they're giving axial traction, why aren't they holding all the fingers?
Because the last finger is directly attached to the ulnar, so I don't think they're very much concerned about that, since it's we want to reduce the radius fracture.
So that's not the reason. The reason is because now if you hold all of them, I want you to hold your own opposite hand, okay, all your fingers. Can you see that your metacarpals form like a very, very deep arch when you hold all four of your fingers? So what happens is when you let go of the little finger, okay, when you let go of the little finger, you're actually able to make sure that your metacarpals don't crowd. Otherwise, what you're doing is you're squeezing them together while you're trying to pull. So when you squeeze them together and you put a cast, that person's not going to be able to flex at the finger, flex at the metacarpophalangeal joints very well. They feel very uncomfortable and it'll be a very tight fit cast. Do you get what I mean?
Yes, ma'am.
So when you hold all four fingers, you cause metacarpal crowding. If you leave the little finger, you avoid that. So if you are ever attempting to do this, make sure that here you interlock your fingers on this end and here you leave the little finger. By giving more traction on the thumb, you can actually give better ulnar deviation, because naturally for the lateral shift and tilt you want to go medial, so that is moving everything ulnarward. Okay, For this, you will give palmar flexion. All right. So ulnar deviation and palmar flexion is how you do it. Okay. And the reason, and for the supination of fragments, this maneuver is only done in pronation. Okay, so it's fairly simple, like the theory of it. Putting it into practice is difficult because it is a team job. You have to have somebody standing here, you have to have someone here, and you have to have the third person actually reducing the fracture by exaggerating this deformity. Okay, and you will basically have to go proximal to the palmar crease. That's the distal most extent of the Coley's cast, and the proximal most is distal to the elbow. So, like now we were discussing about joint above and joint below. Why is it in this particular case we don't do that? Any idea, Judah? Because I'm stopping the cast here and I'm not going above elbow. Why?
Um, I think in this case, mobilization helps the fracture. Like, I don't know how to say it, because if we immobilize it, then what happens if we immobilize it?
So I'll help you out. You've forgotten that there are radio-ulnar joints as well, isn't it? So that's the proximal joint here. Did you get it?
Yes.
Yeah, because you don't want to be them to you. So the idea is that you've immobilized up till here. Okay, so this particular fracture doesn't really require you to go above elbow. All right. Okay, so this is the same patient. Okay, after reduction, very happy. Put a slap, is gone home. Okay, now that you see here, would you like me to zoom in?
Uh,
Okay. Kid would fall on an outstretched hand.
Okay, ma'am, there's a distal distal radius fracture.
Okay,
It's proximal to the growth plate,
very good.
and I think the ulnar styloid's in half.
Yeah, so it's also fractured at the ulnar styloid. Do you know anything
And
that attaches to the ulnar styloid, Judah?
the pisiform.
No, so when we say attachments, we're not talking about articulations. We're talking about, does anything attach over here, like any soft tissue or anything like that?
Are you talking about that complex?
Yes, very good. What is it called?
It's
Excellent.
called triangular
Yes.
TTC something.
Yeah, so it's called the
With it.
TFCC. All
TFCC,
right.
yes.
Yeah, so the TFCC, that's the triangular fibrocartilaginous complex. Okay. So that is attached over here usually. Okay, and it attaches to multiple things. We don't have to go into the theory of that. That's irrelevant. What is the importance of that complex?
It's
And you can see, yeah.
if that joint, if the styloid is fractured, the TFCC becomes unstable. So uh, we need to fix that, and if the patient's able to um, move that joint without pain.
No, so can you see anything peculiar on the lateral?
So I think there's a volar.
This is volar. Sorry, I don't know why this keeps happening. 1 second, hold on. Yeah, so this is the volar side, this is the dorsal side. Okay, because you can see the thumb over here. Basically, that's how you should kind of gauge. Okay, so you can see this is the volar, this is the dorsal. So what's your take? You were about to say something. It was almost correct. Tell me.
Looks like there's a volar shift displacement of the radius.
So I think it's actually a dorsal displacement of the ulna, because that tethering from the TFCC is no longer there. So now you have also got a DRUJ, distal radio ulnar joint, has also been affected. Okay.
Okay.
So this is what we call a physeal injury, all right? The one that you can see with the radius. Do you remember the types of physeal injuries?
Salter Harris classification.
Yeah. So the easy way to remember it is using that exact name, SALTR. Okay. So you draw a bone like this, all right? Type 1 is slipped, okay? Type 2 is above, all right? Type 3 is lower. Type 4, sorry, I'm such an artist, is through. And type 5 is when it's rammed like this. So that's how you remember. Slipped, above, lower, through, rammed. Okay, Salter. So which one do you think this is? And for you to understand, this is the epiphysis, okay, the thing at the bottom.
Uh, it's above.
Very
So
good. So it's a type 2.
2.
And this is for MCQ purposes, guys. This is known as a Thurston-Holland fragment. Okay. So for this patient, what will you do? How will you immobilize this patient? Knowing what you know now.
Um, so there are two problems. One is the radial fracture, and the other is the TFC, this thing, the ulnar
Radial.
styloid.
Hmm.
So I think we would want the radio ulnar joint to be reduced. So we'd have to make sure the fibula is at the right place. I mean, I'm sorry, the ulnar is at the right place, and
Okay, so you can manage this very easily, like conservatively. Okay, this now the problem with this TFCC injuries, if a person presents in an acute setting, always immobilize them in complete supination. Now, if you want to be able to have complete supination without even the slightest amount of forearm pronation possible, you have to go above elbow. Okay, you have to put in this particular patient an above elbow slab in full supination to be able to completely prohibit them from pronating. Okay, any doubts? I know it's a little confusing. Feel free to ask doubts now. Now is the time to ask it.
no doubts.
Okay, so the idea is that you should not be able to go from supination to pronation. The issue is even the slightest amount is allowed even if you put like a Coley's cast. You can allow some amount of pronation. All right. So, and please medicate appropriately. Children, always remember paracetamol 15 mg per kg. Okay. Yeah. Talk me through this one. Do you know what fracture this is?
Is this of the wrist?
Yeah, this is a X-ray of the wrist. I'm sorry, the PA view is not the nicest. I didn't include the ulna. Let's consider that nothing's really wrong with the ulna. Okay, so tell me what you can see here.
So, I can't see I can't find out the orientation, volar or dorsal. I think it looks like a dorsal.
Okay. This is volar. This is
Yeah. So dorsal
okay.
looks like a dorsal displacement, and it's above the growth plate, so it would be type 2.
So this is not a physeal injury because, well, no fracture is going through the physis at all.
Above the. Okay.
It's
Okay.
proximal, isn't it? It's
Okay. Okay.
completely avoiding the physis.
Yes.
So this actually, so this is very common in really small kids. I'm talking about, like, especially toddlers and preschool kids. So when they fall, their bones are super soft. Okay, so if they fall on an outstretched hand, you've got this axial loading that happens, and because it's so soft, the cortex just kind of bulges out like this. Okay, because with all of that axial loading, suddenly there's a give way like this. Do you get what I mean?
Is this what a buckle fracture is?
Sorry?
Is this what is called as a buckle fracture?
This is called a torus fracture. Okay, where you end up, it's a special name fracture. I learned this during bond because there were a lot of trauma cases, and I thankfully had another Johnite who over there who finished his MS ortho, so I learned these things. This is interesting for you all to learn, and these are very common MCQs as well. So just I'm just trying to make sure that we kind of cover all domains. So this is basically, and I agree, it is buckling of the cortex basically, but it's known as a torus fracture. Okay,
Okay, now.
so you can, in all of these, very easily conservatively manage. Please don't think that this case needs to be operated. Put a below elbow slab. Even if you put an above elbow slab in this kid, they will break it within deliberately on their own. They will break it within a week, and they will come back with this like flimsy thing with their arms flailing all over the place. And again, please medicate appropriately. Okay. So, Judah, I'll give you some rest. Who's there? Um, okay, Alicia, you ready to come back?
Yes.
Yeah, hi, Alicia. Okay, tell me, what fractures do you see in front of you? They're both definitely not the same fracture, so you just tell me what you see.
Uh, so in the first X-ray, it's
Mm-hmm.
X-ray pelvis. We can see a break in the Shenton's line,
Okay, yeah, that's over here. Very good. Yeah,
and
then
with neck of femur fracture. Actually,
is it a neck or femur fracture?
mm,
Don't you think this is like a little distal to the intertrochanteric line? I mean, or along the intertrochanteric line? It's definitely
yeah, it's
distal
an
to the neck.
intertrochanteric fracture. Maybe.
Yes, it's an intertrochanteric fracture. You can know because see, the neck ends around here. Okay, you've got your greater trochanter over here, which has now been broken into two pieces like this, and cleanly along the intertrochanteric line, and you've got the lesser trochanter as altogether. So it's quite a nasty fracture actually. Okay, so this is an IT fracture or an intertrochanteric fracture, and this is our old patient that we saw in the beginning. Same neck of fever. Okay, so remember the difference. So here you can see the neck has come till here, and guys, actually, like ideally speaking, these X-rays when you get them done in the hospital, it should be done in traction. So acts like traction this way. All right. So someone needs to be holding the limb. For that, someone else has to be giving counter by holding the axilla of the patient on either side. And so you will basically give traction and 15 degrees of internal rotation for both of the lower limbs, because the neck of the femur is in 15 degrees of anteversion. So if you want to see the whole neck properly, like trying to make the whole neck come in alignment, you want to have to get it in 15 degrees of internal rotation. Otherwise, you may end up missing a fracture. It's happened many times. Just be wary of it, okay? Right. So now the thing with hip fractures, which everyone needs to know, is that you especially in the rural areas, there's delayed presentation. You'll rarely find these people coming on day one. Everyone has this assumption that once a person has fallen down because of pain, they're not able to get up. But even these trivial falls are what cause these, right? So what you need to do is first treat them holistically. A lot of them will come in a little bit neglected, dehydrated. So please, get them back to their former glory. So before you think about referring them for surgery and stuff, if you feel like you're unable to do it, then refer for them to optimize the patient for surgery. Please treat dehydration. Back care. It does not take time to develop bed sores. In a day, a person can develop bed sores. So always do back care. If a patient has presented late to you, there is a very high chance that they've already developed a bed sore. And in that particular patient, what's terrifying is if it's a neck of femur, the treatment is actually to do a hemiarthroplasty. And the incision for that is going to go over a bed sore. And trust me, there's nothing worse than an infected joint replacement. Okay, so it is a nightmare. You'd rather leave the patient as is. So please learn. You can always learn back care even in YouTube videos, how to massage. It improves the blood circulation, lymphatic drainage and everything of the gluteal region. So it's extremely important. Don't take it for granted. For the same reason, acquiring an air mattress or a water bed is extremely important. Catheterize the patient for two reasons. One is if they're dehydrated, you must monitor urine output. Okay. Other thing is that you want to be able to make sure they don't constantly soil themselves. All these old ajis and ajas, their skin's very friable. Yeah. So what happens is you can macerate it quite badly if they end up soiling themselves regularly. Yeah, then put them in a diaper. Skin traction with 2 kgs. See, a lot of y'all may not have the things for skin traction. If you don't, you can do this. This is called a derotation boot. This was the one where I had made a mistake about the little toe. You can see there's a wooden bar over here, okay, where you can actually, so you make a cast that goes around and you can actually use this bar, tie two ropes on the side and hang 2 kgs of anything. It could be 2 kgs of rice, dal, whatever you have lying around or whatever you can ask them to go pick up, which is cheap. Only problem with this derotation boot, which I mean I don't like, is the fact that they can't they can't move at the ankle, and that usually moving at the ankle kind of activates the gastrosoleus pump, right, peripheral heart, so you get better blood going back. So that's my biggest issue with this, because they're already kind of immobilized in bed, very high chances of getting DVT. A lot of other problems associated with prolonged recumbency, like we discussed the bed sores, and also pneumonia, very high chance of them developing pneumonia. Please refer for surgery. Even if you think that the patient is very comorbid, please urge them to get surgery done, because if it's a neck femur fracture, knowing again, this is a very important thing, knowing their pre-injury ambulatory status, okay, is extremely important for this reason, because if that person was able to walk around perfectly fine and is now bedridden, this surgery, like a hemiarthroplasty, they can start weight bearing. It's a excellent surgery. Patient goes in and within 2 days is walking. So the other thing is, for IT fractures, we do a PFN. Okay, that's a proximal femoral nail. You can still mobilize them in the bed. So all of the other problems sort of, get avoided at least. Okay, yeah, tell me, Alicia. This is our same kid from earlier. Do you remember?
Yes.
Yeah. So what slab is this?
This is a mm,
Look at the shape of it. What is it shaped like?
U slab. U slab.
Very good. Okay, you slap. So you can move. So this is the same kid whose X-ray you saw earlier. I didn't show you the baby because I wanted to discuss the slab. So here when you measure, please measure from the nape of the neck to the axilla. So you'll measure like this. Okay. What we used to do is after measuring it and when you make all of the layers, right? By the way, Alicia, how many layers will you put for an upper limb slab? How many will you put for a lower limb slab?
14 for an upper limb slab, 12 to 14, and for lower limb 16 fold.
Okay, 16 to 18.
To
Very good.
18. Yeah.
Yeah, excellent. Okay, so and this is because we have low quality POP. Actually, you can do 10 to 12 for upper limb and you can do 14 to 16 for lower limb. But then, depending on how shit your POP is, you take a call. Okay, so what we used to do is pierce 2 holes like this with a 11 blade, and then pass like a gauze roll through it. What happens is that this edge, right, it comes over here, it gets frayed, and it's very irritating for the patient. So I learned this thing during postgrad where whatever you've measured here, if you double it in length, right? Okay, so say we've got this much length, and then you take the same rope that you're going to use and put the center of it through the center of this. And then you just fold this over and keep this at the folded margin. Okay. Then what happens is you've got a nice rounded edge. Causes a lot less discomfort for the patient. I found that patients are a lot more compliant with the slab because of that. They don't try to like manipulate it too much. Make sure you've got good amount of padding. Use a 6-inch soft band or cotton rolls. Cover from here on the top, wind around in the axilla and lower down. And then when you put the POP, you have to take help from people. Okay, so when you're applying it like this, the folded edge is here. You've got the whatever gauze roll that you've got, it comes around here, and the other one's on the other side over here. And you ask an assistant to just hold it in this position so that it doesn't slip down while you're trying to secure it. And you go around with gauze like you can see over here. Okay, and finally at the end, you will take this and you will just tie a knot over here, and please put a separate sling. So here you can see this little guy's got a thing tied around here. Okay. Did everyone pick up on that? If please raise your hand if you've got a doubt, okay, about these things. I don't want it to go over everyone's head because I feel like these are important skills that you can definitely apply during bond. Okay. Yeah. So tell me what this is. We're almost at the end.
This is the fracture of shaft of radius fracture.
Baba, it's written here.
Oh, Galeazzi.
So, what happens in a Galeazzi fracture? Is it only a fracture? Or is it a fracture dislocation?
Fracture with dislocation.
Yeah, so it's a fracture dislocation. So you've got a fracture of the radius, and can you see the ulna has gone displaced backwards? See, this is a fracture of necessity. Okay, what does that mean? That means that this person needs surgery. You can splint them by immobilizing at the wrist and the elbow, and that is using a above elbow slab in mid prone or whichever position the patient is comfortable in, because that's not the final treatment. They definitely need surgery. Okay. Okay, so this, I know everyone's tired and this may end up going over your head. I feel like for things like spine fractures, we need to discuss it in greater detail in another session for sure. Can you see the fracture in the lateral view on this X-ray, Alicia?
No.
Okay, so this is the sacral. Okay, so this is L5 over here. This is L4. This is L3. This is L2. This is L1. Which looks the smallest?
L1.
Very good. Don't you think, is it looking like a nice box like the rest of them?
No, there's compression of.
Yeah, it's a compression fracture. Very good. Okay. So these patients, please, if you don't have one, try to make one. Please get a spine board. Log rolling we'll have to do in a practical session because I think it's a very important skill. I can put a link on how to log roll. I'll put it on the group. Most common mechanism, fall from height. Other thing is also RTAs, where you get what we call a chance fracture. This is the wrong X-ray for this patient. That's why I put this up, because here it's a lumbosacral spine X-ray. The most commonly affected part spine fractures, the thoracolumbar spine, not the lumbosacral spine. At the thoracolumbar junction. That's why you've got your L1 here and your T12. So you'll always have this problem. Other issue is you've got the spinal cord ending around here. So the chances of cauda equina and conus medullaris syndromes are very, very high. We'll have to discuss that in detail in another session. I think that's beyond the scope of this. Always do an abdominal examination in these patients because there are a lot of retroperitoneal structures that are vital, especially the great vessels and whatnot. Okay, and do a neurological examination. Catheterize these patients before you refer them out. Okay. If you want a detailed discussion on any of these things, I think it's something we'll have to actually make separate time for. And I tried to cover as many topics as possible, but it's not easy to know exactly the issues you all are facing and what types of fractures you all are dealing with. So I would really, really like if you guys want to discuss any particular fractures or anything, please, you can, if you don't want to message on the group, that's perfectly fine. You can always get in touch with me directly on WhatsApp. You can DM me. I have never said no to a joinite. So don't hold back. Okay. Thanks for hanging around. I just realized we've crossed an hour and a half, and I apologize profusely, guys. I know this is not the ideal way to spend a Sunday evening. So thanks a lot. All of y'all who are here, please do. It would help me if you could fill out the feedback form that Tijo would be sending on the group as well. And I hope if y'all learned something out of all of this instead of me just rambling. Okay, so great. I'll hand over to.
Yeah, thank you all for joining. Thank you, Kiana, for spending the Sunday weekend with us. I hope you found the session useful and has enabled you to manage trauma better. That is a really interactive and useful session. And thank you for dedicating some time for this webinar in between your busy schedule, Kiana. A few things to note before we end. Feedback form is shared on the chat box and join it academic WhatsApp group. Please fill it out before you leave the meeting. The recordings of the past sessions and this session will be posted on YouTube. It will be on the St. John's Medical College Alumni Association YouTube channel. Once again, thank you all. Thank you, Kiana. We'll meet again with another interesting topic. And as she said, please send your feedback and send any suggestions for further sessions to her directly or on the group. And the details of the further sessions will be posted on our social media channels. Thank you all and have a good night.
Thank you, ma'am.